Good evening, everyone. I am Dr. Rosh, Senior Resident, Second Year Resident at the Department of Plastic Surgery, Government Medical College, Thrissur. I am presenting a case of 60-year-old male manual laborer who is coming from Palakkad, whose presenting complaint was a lesion at the right side of the mouth of right side intraoral cavity, 3-month duration. History of present illness. The patient's complaint started 3 months ago as a growth in the left lower side of the gum and cheek, which gradually increased in size to attain the present size. The patient complains of bleeding to touch and while the trivial trauma. He also complains of halitosis. There is history of excessive salivation, and there is history of loss of one tooth. His one molar was loose and it was removed. Other than that, there was no history of any associated neck swellings. There was no history of any radiating pain, no earache. There is no difficulty in chewing or mouth opening. No history of change in voice or hoarseness of voice. There was no history of cough, hemoptysis, no history of bone pain, no history of abdominal distension, no history of any significant loss of weight or loss of appetite. Coming to his past history, there is no history of hypertension, diabetes, tuberculosis, bronchial asthma, COPD, coronary artery disease, or CVA. There is no history of any other surgeries in the past. Personal history. He has a history of 20 pack years, smoking of 20 pack years of cigarette. He is an occasional alcoholic and history of occasional pan chewing. Family history, there is no significant family history. There is no history of similarness in his family. Socioeconomic history, he hails from a low socioeconomic status. General examination, the patient is conscious, oriented in time, place, and person. His vitals were stable. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or generalized edema. His BMI was 20 kg per meter square. Coming to his local examination, inspection, extraoral examination, the facial symmetry was maintained. There is no swelling, scars, or sinuses in the neck or head. Mouth opening, there was no restriction in mouth opening, and commissures were intact. Intraoral examination revealed a single ulceroproliferative growth of approximately 5 × 3 cm along the left buccal mucosa and the lower gingivobuccal sulcus, extending posteriorly from the first premolar approximately 1.5 cm anterior to the retromolar trigon to the second premolar and from the first molar approximately 1.5 cm anterior to the retromolar trigon up to the second premolar anteriorly and laterally extending 2.2 cm on the buccal mucosa and medially onto the lateral border of the gingiva. The lesion was having irregular margins with everted edges. The surrounding mucosa was not inflamed. There was no slough, bleeding, or pus discharge. There was no other areas of leukoplakia, erythroplakia, or submucous fibrosis in the other areas of the oral cavity. The oral hygiene was poor with dental caries. The first lower molar on the left side was absent. Sharp tooth edges were sharp. There was nicotine staining. There was no restriction in mouth opening. There was no restriction in tongue mobility. There was no fullness noted in the neck. The facial artery pulsations were palpable. Possible donor sites were inspected and found to be adequate. Coming to palpation, there was no local rise of temperature. Tenderness was present over the lesion. Mouth opening was 3 finger, and inspection findings were confirmed. Induration was present on the mandible within the margin of the lesion. There was no paresthesia in the infraorbital or the infraalveolar nerve region. The retromolar trigon was free. There was first molar loss noted. Taste sensations were normal. There were no other lost tooths. No clinically palpable lymph nodes on the same or opposite side. And skin was not involved clinically. My diagnosis would be an ulceroproliferative growth of the left buccal mucosa, left lower buccal mucosa and the lower gingivobuccal sulcus with involvement of the mandible, probably squamous cell carcinoma. The stage would be T4A, N0, M0, with the staging being stage 4A disease. That completes the case presentation, sir.
So how can you stage it before or CT scan?
Sir, the CT scan report was not available. I took
go back to previous slide. Yes. Next slide. Next slide. Next slide. Next. Where you have written the diagnosis, because yes. So you say it is T4AC N0M0. Okay.
Yes, sir.
You didn't do the CT. You didn't see the CT, and
Yes.
How come you have reached to this conclusion?
Sir, since the induration was involving the gingiva and extending on to the mid portion of the gingiva,
Okay.
I assumed that the mandible would be involved. It was
okay,
and
Okay,
the
got
clinical
it.
N0 staging was taken.
Yes. So clinical N0. So what do you look for in CT scan? Why do we do CT scan?
Sir, CT scan is done to assess the lesion, involvement of the buccinator or subcutaneous tissue on the cheek, and also to look for the involvement of the mandible.
Okay. So CT scan is mostly for the soft tissues, because whatever you are saying, it is soft tissues.
No, sir, it's also for the involvement of the mandible.
Yes, it's mainly for the bone, but what additional advantage of CT scan for the staging? Because if we go the TNM staging, it is on the basis of the once you do the CT scan, only then you are able to do the TNM staging. So what additional findings you will have on CT scan, which you cannot have clinically?
Sir, involvement of the skull base, involvement of the perineural canal nerve.
Just don't go to the skull base or anything. First of all, you see it is T, N, and M. Okay.
Yes, sir.
So T you can do by examination. What about N?
N clinically can only be assessed whether the nodes, clinical palpable nodes, but whether the bilateral nodes are involved, what the size of the nodes, everything. The
Yes,
staging.
size. Here it is important. Size, location of the node. So size, this is very important, because you cannot palpate the subcentimetric node. So if you do CT scan, you will see those nodes. This will really helps you to design your stage, because it is going to change your plan.
Okay.
Got it?
Yes, sir.
Because if it is N0, what kind of neck dissection you are going to do?
It would be a supra-omohyoid neck dissection.
Selective neck dissection. Okay. And if it is N1, you might be doing MR ending.
Yes, sir.
Okay. So that's why importance of the CT scan. So whenever you just go to diagnosis, always write it is provisional diagnosis. Okay.
Okay, sir.
Got it. And
yes,
before staging, you should say that I would like to do few investigations, biopsy to confirm my diagnosis, CT scan for the staging. You just go like this.
Okay, sir.
And at one point in history, you said that so you were talking about some perineural invasion. What do you mean by that?
Sir?
Perineural invasion. You just mentioned something. You were talking about.
Sir,
There is no paresthesia.
Of the canal. There was no paresthesia.
So where do you look for the paresthesias?
In the infraalveolar region and the infraorbital
I don't
region.
understand. I don't understand infraalveolar region. So where exactly? Got it? What I'm asking.
Yes, sir.
So it is a friendly discussion, but you should know this. Okay.
Okay, sir.
So what? Suppose how will you find out that nerve involvement is there or not? What are the ways? That's why CT scan is important.
Okay, sir.
Okay. So because if you have, sometimes you don't have any this features clinically, but if you see on CT, there's a widening of the canal, some irregular margin in the canal. So then it is going to change your plan. That's why it is very important. Suppose your canal is involved, how would it leads to change your plan?
Sir, the length of the mandible to be excised should involve the whole of the canal.
So up to where to where? I don't know where is the canal actually.
Sir,
You just name the point. You name the point.
Sir, from the mental foramen onto the angle of mandible.
Angle of mandible. Okay. So now enter at angle of mandible.
Yes, sir.
Sure?
I'm not sure, sir.
Okay. Okay. So it enters at lingua, which is in the ramus. So you go, your excision goes proximal to that. Okay.
Okay.
So because that's why the importance of these investigations, and whenever you're excising, you should go because it is changing your plan. Na?
Yes,
it's
sir.
changed whole of the plan. Okay, just go ahead.
Now I would like to do diagnostic investigations to confirm my diagnosis. First, I would like to get I would do an incision biopsy to confirm whether it's a malignancy. I would also like to do a contrast enhanced CT with a puff cheek view to assess first the bone involvement, then to assess the buccinator and subcutaneous tissue involvement. Then pan endoscopy to rule out other synchronous lesions. Then I would like also to do a ultrasound abdomen and a chest X-ray as part of a metastatic workup.
Okay. So what is pan endoscopy or triple endoscopy?
Sir, laryngoscopy. Laryngoscopy and indirect laryngoscopy, upper GI endoscopy, and bronchoscopy.
Okay. And how do you do this incision biopsy?
Sir, wedge biopsy would be taken along with the normal tissue to assess the diagnosis and the depth of invasion.
So how do you take it? Do you take it with the cautery or with the knife?
With a knife, sir, under local anesthesia, with a knife, the incision biopsy is taken.
Okay, and once you've taken the biopsy, so what are the type of malignancy you suspect in oral cavity? One, and biopsy में क्या लिखा हुआ आएगा? Did you get me? What they usually?
Most probably it would be a squamous cell carcinoma, sir.
So okay, what do you see in squamous cell carcinoma? थोड़ा pathology. It's little bit pathology. Okay, नहीं पता तो पढ़ लेना. Leave it. Go. So next slide. Come to the next slide.
After evaluating the patient for anesthesia fitness, I'll plan the management. My plan of management would be a wide local excision with a 1 centimeter margin with a segmental mandibulectomy, leading to a defect of 7 cross 5 centimeter with 7 centimeter of mandible removed. Along with that, modified radical neck dissection.
Okay.
Would be done.
Hold on. Yeah. 7 into 5 centimeter of mandible, central segment or ramus or body.
Body of the mandible.
Where? Which side? Right side, left side?
Left side. Left. Left.
So this is very important here. You have to describe your defect nicely. Does it involve upper GB sulcus, lower GB sulcus, vestibule, floor of mouth, tongue is involved or not? How is the tongue movement? So once you are excising it, that is very important. This segmental mandibularity doesn't stand anywhere. Got it? Okay. 7 into 5 centimeter mandible, you just harvest the mandible fibula and put 7 to 5 centimeter. How which 5 centimeter where? Anterior direction, posterior, lining, cover, where?
Sir, the body of the mandible along with the buccal mucosa reaching up to the angle of mandible, extending from the first premolar.
Okay, so it is from first premolar to molar. Okay, this is the
Yes,
length. So it is 7 centimeter. I doubt.
Sir.
It is not possible. Premolar to molar, it cannot be 7 centimeter.
Sir,
Okay.
Since the lesion was approximately 5, I added 1
Okay,
centimeter.
okay. So I'm just dissecting the things. Okay, just take it easy. And here, important thing is not only that how much mandible is involved. The most important thing is sulcus is involved or not, because sulcus, the shape of the sulcus, you have to understand, it is a U shape. So you have to double your dimensions, because you will require more tissue to feed in if you want to create the sulcus. So that's why the importance of defect, knowing preoperatively, it is very, very important. Otherwise, you will efface the sulcus and there will be drooling of the saliva.
Okay.
Got it? So you have to create a sulcus in the U shape. No? So that's why it is important. If it is involving the sulcus or not, it is a very important point whenever you are talking about the mandibular malignancy. So इसको अच्छे से करना है तुमको कि anterior posterior इतना है, medially कहाँ जा रहा है, you have to tell everything. तभी better है, because otherwise you will stuck in examination part only. Okay, if you explain this nicely, you are through. Chalo. Okay, next slide.
My reconstructive options after resection would be first the free osteocutaneous fibular flap along with skin paddle. The second option would be pectoralis major myocutaneous flap with the fifth rib as graft. Then my third option would be a DCIA flap. The fourth option would be a scapular free flap. And finally, a sternocleidomastoid muscle with the clavicle graft from the contralateral side. These will be my reconstructive options.
Okay.
Before starting the procedure, we usually the procedure is done under general anesthesia. Tracheostomy is put as elective tracheostomy is done, and a lip split incision is put, and it's extended into a Schaubinger incision for the resection along with the neck dissection.
Okay, so this is the Schaubinger incision for the neck dissection. Okay.
Yes, sir.
So you do neck dissection first, or you will take out the tumor first?
Sir, first we'll take out the tumor, and then we'll go with the neck dissection.
Sure. Do you have any help right now? Can anybody help you?
No, sir.
Nobody can help you at this time. Okay, this is your exams. Huh? Okay. I say I will do neck dissection first, and then I'll go to the tumor. Do you have any common, use your common sense and tell me, either prove me wrong or prove you right, whatever.
Sir, if the neck dissection is done primarily, then the vessels, the preparation of that area would be easier after before the resection.
An interesting question. It's really interesting question. You should do neck dissection first, not the tumor first. Now tell me why, if you know.
No, sir, I don't know.
If you do the tumor handling, what happened?
Dissemination.
Yes.
Tumor dissemination.
So
first the neck dissection should be done, and late after along the lymphatics are once removed, then tumor dissemination will not happen. I'm not sure, sir.
No, this is right. I think you're right. This is simple. Okay. So
okay,
if you see onco colleague, they always do neck dissection first and then move to the tumor. Okay. And okay, what else you will tell your oncologic colleague that I need this, I need that, so please preserve that? Do you say anything before
We'll
surgery?
ask, we ask if possible to preserve the facial artery, facial vessels.
And what about vein?
Facial vessels, sir. Facial artery and vein. Vein.
That's all. That's all. Okay. Okay. Okay.
Sir, this will be my planning for the free fibular free flap.
Okay. So why did you plan this skin pedals in the center of the fibula? I think
sir,
it's really little high.
It's higher, sir.
Why?
Sir, since as I thought the length of the fibula can be preserved. The initial
Which length you want to preserve?
sir,
Distal to proximal?
distal length could have been preserved if the paddle was a little higher. That was my idea, but
what is the advantage of that? If you preserve the distal length more than 8 centimeter, so leave it 6. So chalo chhod dete hain. We'll come to the 8. Okay, preserve 8. Beyond 8, what is the advantage of that?
No particular advantage, sir. Because
and what is the problem you will face if you keep your skin pedal here? How much pedicle length you will get?
The pedicle length will be decreased.
So how much pedicle length you require? If suppose you have to do, you don't get good facial vessel, which will be your second choice? What will be your
superior thyroid artery.
So will your pedal reach there?
No, sir, it will not.
So then why are you doing fibula then?
Yes, sir. So
because it's a two-team approach, no?
Yes,
they
sir.
are operating on the head end and you are operating on the foot end, and you harvest the fibula, and then suddenly you say our pedicle length short. Then what you will do? You will put vein graft?
No, sir.
नहीं नो सर क्या करना ही पड़ेगा ना फिबुला को फैक्ट करना देगा
vein graft should be
so फिर then but why? So that's why planning is very important here. If any examiner see this planning, I don't think anybody will agree to you. You always start from distal to proximal. You're keeping your fibula in this pedal in this bang in the center of the okay. चलो आगे चलो. Am I the only examiner? Yeah, just tell me. Sundeep.
Bhattacharya sir. I think sir is not there. I think right now.
So you can ask something, yeah. Otherwise.
Right. I think you've done actually a pretty good job in the how you have explained things over here, right? So again, the question that I had asked previously, I think definitely you would know that. See, when you're actually dissecting the fibula, what if you don't see a perforator? Usually you said the perforator would be in the middle third of the leg, right? Yes. Suppose you don't get a perforator there. See, why in particular I'm telling you about this particular question is, no? So you have marked out a pretty small flap out. The skin pad is pretty small. So in this particular case, how are you going to make your incision?
Sir,
because if you see, the anterior portion is almost like a small hillock. No, it's a very, very small area that you have got over there.
Sir, I am not sure, sir.
Yeah. So the thing is, no, if you're going to commit to your incision over there, because it's a very small, this one, you've marked out a perforator over there. See, sometimes a perforator might be a bit tricky. So it is not a good idea to actually make this kind of a V kind of an incision in the anterior portion. Okay. So what I would suggest is that you actually make slightly larger curvilinear incision right up front. Go and identify your perforator. Make sure your perforator is there. Then you want to retain some amount of tissue. It is okay, but it is not a good idea to actually commit to a very small flap initially. So those are some things that that is one thing that I wanted to ask. Otherwise, I think it's more or less, I think Dr. Sunil has actually asked you most of the questions. Right? Dr. Sunil, I don't have anything more to ask him right now.
Okay. So I think we can move to the next slide as well then, because you have to grossly see that. Okay. So now
Yes,
you're
sir,
going to talk about pec measure as well.
next,
Again, there is a flaw in the pedal. Again, there's a big flaw in the skin pedal.
Yeah. It is big enough to actually land you in big trouble.
Yes.
it's below the 6th rib, sir.
Okay, but will it reach? Did you plan in reverse?
Yes, sir.
You
But
sure? It will
sir,
reach?
actually, I did not have the actual patient. I actually had the details
Virtual
and
patient.
sir, virtual patient.
So, but you I think you must be having books with you.
Yes, sir.
What does book suggest? Your pedal should be inferior middle portion of the. What is the attachment of pec measure? Origin insertion.
It's inserted onto the lips of the humeral
Okay, that is insertion origin.
origin from the first to 6th rib, sir.
Okay, that's why you are ending at 6th. Suppose you go beyond the 6th rib, your skin pedal goes beyond the 6th rib. What happens? It won't survive.
Sir.
Seriously?
Sir.
No, it's not like that. Okay, chalo. This pedal is totally wrong. You because it won't reach. I'm telling you, I'm very sure about it.
100%.
And it won't reach. So you have to go little distal, and there will be an osmosis between the IMA and this superior inferior gastric artery and the So have you read about the concept of chalk vessels? What is chalk vessels?
Chalk vessels are vessels with angio small vessels which connect between different angiosomes.
So first, though, you have to correct it. As Sundeep has already said that you will be in brick table if you mark like this in exam. I must tell you. Okay, so you always go inferior middle aspect of the nipple. You go distally. First, you mark the DP here. Then you mark your pec major, and your incision should not cross the DP flap because you try to always. Okay.
Yes, sir.
So your approach is very important. Your incision go to this lateral side. Okay. So you first mark the DP, leave it. Any incision should not cross the DP. So you go like this, you raise your flap and then transfer. Okay.
Ideally, Rosh, you should actually have two different colors also. Like what
Yes.
Dr. Sunil said, what we normally tell is that we ask them to mark the DP area in one color and the pec major in another color. So then the examiner would upfront itself, he would know that, okay, this guy knows what he is doing. So that is what you want. You don't want unnecessary questions from the examiner to you.
Yeah. Because if you mark nicely, questions are over because everybody has limited questions. Okay. Then they go to the specific questions. When you reach to the specific question, you are already through the exam.
Sir, I'm unable to.
Whenever you harvest pec major, you have to mark the DP first. Do you know this? Whenever you are harvesting a pec major, you should try to preserve
sir, I am unable to hear the voice, sir.
Nobody's voice? Okay. You're not. I'm able to hear Dr. Sunil's voice. Are you able to hear? Are you able to hear my voice? Dr. Rosho, are you able to hear my voice? Rosho, we are able to hear you also. I think there is some problem with your.
Sir, I'm not sure, but I am unable to hear the voice.
Are you hearing through your computer's speakers, or how are you hearing? Or is it a Bluetooth or something? Oh. Anyway, we are able to hear you. That is the thing.
Yes, sir. Okay, it's now clear.
Okay, fine.
Small problem with my system.
Okay, fine.
So Rosho, you
So-
just tell us, how do you harvest a pect major and how do you plan it? Do you always mark DP first or not?
Yes, sir. First, DP should be marked as a part of a guarded approach.
Okay.
The DP is marked based first the clavicle is marked, then the sternum is marked, and 2 centimeter 2 centimeter lateral to the lateral border of sternum is marked. Then the 3 intercostal spaces are marked, the second, third, and fourth intercostal spaces. Then the delta vectoral groove is marked. Then the DP flap is initially marked, and below that the PMMC paddle should be marked. For marking the PMMC paddle, the acromion to the sternoclavicular joint line is drawn. The lateral to 2/3 and lateral medial 2/3 lateral 1/3 junction is connected, and the line is joined from the acromion to the CP sternum. Line is dropped at the junction of the lateral 1/3 medial 2/3 onto the acromio CP line, and this will be marked. This will be marking the thoracoacromial vessel. And first the skin paddle is marked, and after reverse planning, the skin paddle is marked and the skin paddle is raised. Then the vectoralis, then the fascia is tacked down to the then the pectoralis dissection is proceeded all around, and the pectoralis major muscle is
Okay. So tell us, what is the blood supply of pect major?
thoracoacromial vessel, and along with that the internal thoracic artery, internal mammary artery perforators.
Thoracoacromial is a branch of which vessel?
It's subclavian vessel.
Acha, which part? So whenever you are doing anything, you should know everything about that. At least basic, simple things. Okay. And what are the problem with the pect majors? When you transfer the pect major, the most common problem you will face with the pect major?
It is to tunneling it into the oral cavity.
Well, in most ways, that is not a problem. You make a 4-finger tunnel, it will easily cause it. On day 2, you see that your skin pedal is not viable. What is the reason?
The pedicle is turned and kicking of the pedicle.
Okay, twisting of pedicle 1, which is unlikely if you keep enough base. 4 centimeter, 2 centimeter muscle rakhega to nahi hogi twisting. So what is the most common reason?
The tension on the.
Why you are taking suture from fascia, muscular fascia to the skin?
To avoid shearing of the fascia from the subcutaneous tissue.
What
from the
happens if
dermis.
it does? So
the blood supply to the dermis will be lost, and that will cause necrosis.
So suppose it happens, if you see on day 2 there is a color change in the skin, you always check for the muscle, that muscle is viable. So even then you can prevent the fistula formation. So that's why this is the most common reason of flap loss in pect major, shearing of the. So that's why you take the sutures. Sir, aap pucho.
Yeah. So see, the thing is, we must understand that the post-operative period, the edema is actually going to also come into play. So So practically, when we take all these muscles, we have to consider the space. I think it should be pretty large space, much more than I think 4 is probably the minimum. 4-finger space must be the minimum, and I think the larger it is going to be, the better. So that is one important thing that you have to actually to do. So, so this defensive approach you said, no?
Yes, sir.
Rosh, yeah. So, why do you do that?
Sir, so as to preserve the DP, delta pectoral flap.
Okay.
So that in case a lifeboat is needed for the cover, it can be used.
Okay. Okay. So let me just ask you a simple question. Suppose you have a through and through lesion. Which one are you going to use in which area? What is going to be the lining? What is going to be the cover?
Sir, the DP will form the cover and the pectoralis major will form the lining.
Okay. And you know the pivot point of the DP?
The DP's pivot point will be the second intercostal, fourth intercostal vertebrae.
Fourth.
Yes, sir.
Are you sure?
No, sir. It's at the sternoclavicular joint. It's the second intercostal vertebrae.
Why?
I don't know, sir.
That is because of the peculiar anatomy, that that movement of the tissue is much more in the lower portion. See, ideally, it is because that arms are actually, our body is designed in such a way that the arms, you go for arm abduction of the arms. So actually, the lower portion, even though we feel that it is shorter distance, it is more pliable. So that is why the upper portion is considered, that is a pivot point over there, because the shortest distance is for the considering the pivot point. Okay, so that is probably the peculiarity of this particular flap. Right, and that is it. I think more or less done.
Yeah. Okay.
Rosh was you had a case presentation for the CalPlast, no? Last week.
Yes, sir.
Week before last.
Yes, sir.
So there you had presented pretty well. You're more confident over there than you're here today. I think today a bit.
Actually, I had not had the real planning on a virtual patient was kind of
slightly more difficult. Yes.
Yeah. That's a problem.
Dr. Umar. Yeah, Dr. Umar. Any questions you want to ask Roshjo?
I think he has been bombarded. All has been asked. Most of it has been asked. Nothing remains. Only I can say that for a student like him, DP flap and the packed major flap should be very stoutly read. They are the very old. We used to do them initially. Now pre-flap time has come, but their value has not decreased.
Absolutely.
So what is the pivot point is the most commonly asked? Why should we preserve the DP? What are the lines we have to mark? What are the various methods of taking the packed major to the neck or the face? These are the very important things, and these are to be read by the students, even in this microsurgical era also. I can say that only.
Is there any other way of actually reconstructing giving the lining other than these things that you have mentioned? Let us imagine that all these things are again gone. So is there any other way that you can think of to give a lining?
Sir, fibula flap. Sir.
Yeah, fibula flap. The lining is gone. For some reason, the lining has been gone. So now how will you reconstruct it? Or the lining was inadequate. So then what are you going to do? Partial necrosis, something like that. So the options, we should know the options. What are the available options? One, you said you have got the pectoralis major. Okay, fine. The problem with pectoralis major is, once you're actually you have FHL over there, some other tissues over there. You might, and you're actually pushing it into the lining and the floor of mouth. It might be a bit bulky over there. So that is one thing, but then that is our work cost. For some reason, you are not using it. For some other reason, maybe it has been already taken or some other reason. So then what is the other available flaps? That is the question that I'm asking. So yeah, you
one
want
is
to answer
the
now?
deep circumciliac artery flap, DCIA flap can be.
You're losing one free flap, and then again you want to go and use the same another free flap for that. It's a salvage procedure. You're going to salvage your fibula. Your fibula, I mean, probably the bone is worked, but the muscle paddle is the skin paddle is gone. Then what are you going to do?
So the first one thing would be the considering the pectoralis major myocutaneous flap
Okay,
itself.
yes. Okay. So your PMMC area has already been violated. So then what are you going to do?
Sir, submental.
Submental is going to be, you already, haven't you done a neck dissection?
Yes, sir, neck dissection.
Then?
I don't know, sir.
Forehead flap?
Sir, forehead flap, whenever that question comes, it always mentioned that that should be an obsolete flap. We usually do it frequently, forehead flap.
Which
That's
forehead
why
flap? Which forehead flap you use?
Sir, the conventional forehead flap using
No. There's a name for that. There's no conventional and modern and all. What is the name of the forehead flap?
And if you tell the
lateral,
name, then I'll ask next question.
Lateral.
Do you delay it or not? And these are things. I'm giving you the hints. Scalping.
Yeah, sir.
Scalping flap.
No.
So can you tell us a bit about, you said your department, you're using forehead flaps quite often. Can you just tell us a bit about how we are going to raise your flap?
The flap is raised first. Usually we delay the flap and
here though you don't have choice now. You don't have choice for the delay because bone is already exposed. You have to cover it.
The flap is planned in the forehead from the lateral temporal region. The flap is
based on which vessel?
Supratemporal vessel.
Which vessel?
Which vessel? Is it just like that, or
it's which branch of that particular vessel? Superficial temporal vessel has two branches, na? So it is based on a whole vessel or on one branch. And what will happen to the excesses of the forehead?
He's a free flap person.
Yes, sorry, sir. I am.
Okay, fine. In which plane are you going to actually do the dissection?
In the supra. Sir, I am.
Okay, so see, the questions that are going to be asked is, okay, what is a plane? It's a very simple flap. It's a robust flap. It is something which you don't have to condemn it also. See, now it's a era of free flaps, and then not always you will be able to do a free flap. No? For some reasons, you might not be able to do a free flap. So these flaps are also very important. It is something that you must know. You're not doing it on a for every case. You might not be doing for every case, but at certain points, this might be a lifesaver for that particular patient. So it is something that has to be learned. Okay. So now the important thing is, what is a vessel? What is the depth of your dissection? Okay. You're actually going to take it just above the periosteum. Then what is the superior portion? What is the inferior portion? So these are the things that you should know. And then the next thing is that how are you, at what point how are you going to take it inside your oral cavity? So these are the things that are going to be asked. Yeah, can you answer that?
Sir, it can be tunneled into the oral cavity after putting an incision in the ramus region. It can be tunneled into the oral cavity to create the lining.
Above the zygoma, under the zygomatic arch.
Under the zygomatic arch.
Oh. Trap.
That is us. So see, these fundamental things you should not go wrong on them. Okay, because it is something that has to be. It is just like in case I have actually personally seen now what we say these are lesser flaps, but I have actually seen one of examiner a place where I've been one examiner, he asked how to actually raise a pectoralis major and then what is the surface markings, how are you going to do, and when the examinee was not able to answer it, he just walked out. It took a lot of convincing for him to come back into the examination hall. So I think we should be very careful. We should know these flaps in and out. Okay. Right. Dr. Umar, anything further? If not, I think it is getting pretty late. It is 7:30.
Yes.
Shall we call it a day, Dr. Sunil?
Yeah, sure. I think he did a good job, although, but I think nobody will take this spec major message along with them. So I hope next time you get prepared with the local flap as well. Okay. Okay, na? Fibula, still we can take it. You are marking the flap in the center small. That is okay. But this nobody can take. So
Right.
thank you, Dr. Sundeep, for the kind words.
Thank you very much,
thank you
Dr.
very much,
Sunil, for actually taking so much time and
Oh,
explaining in detail and answering all the questions so nicely. You have taken so much effort in actually making this particular presentation also. So thank you very much for joining us.
Thank you. Thank you.
Okay. Thank you, Rosh. You have done a good job.
You, sir.
Don't worry, no worries. You've
Yeah.
done pretty well. Don't worry. Okay.
Thank you.
Yeah. Small ironing to be done. That is all. Okay. So, Dr. Umar, thanks a lot for being part of the team. I think Bhattacharya sir had to leave early today. Thank you very much and good night.
Thank you. Thank you, sir.
Bye. Bye. Sharika, thanks to you also.
Thank you, sir.